Okay, hi, welcome. We're going to be discussing cerebrovascular accidents or strokes today, so enjoy. So to start off with, think about what you already know about cerebrovascular accidents and think about what kind of problems, what kind of signs and symptoms do you associate with a stroke generally? Whether it's been patients you've worked with in an acute care setting or whether long-term care like in a nursing home, what are some of the problems and things that you've experienced or that you've read about or know about already that you associate with a stroke? And then based on that, what kind of nursing care are you expecting they need or have you seen that they need? Just kind of think about that for a moment and kind of recall what you've seen already. And a lot of that's going to come into play as we go forward in the rest of the lecture. You're probably going to see a lot of stuff that you're already familiar with, and maybe some stuff that'll make a lot more sense that you've seen done now that we talk about it today. So about 795,000 strokes happen in the US every year. Of those, about 130,000 people in the US die from their strokes every year. And of all those strokes, 87%, so about 9 in 10 strokes, are the result of ischemic attacks. So ischemic meaning obviously a lack of blood flow to an area. That's usually caused by an embolism or a thrombus formation. That could also be the result of athero or arteriosclerosis. So again, it's a pretty significant number. It's almost 1 million people every year. And again, about 90% of those strokes are going to be ischemic. There are some differences between different types of strokes, and we're going to talk about that coming up, but the vast majority of strokes are ischemic strokes. So recalling 2 slides ago when I asked you to think about what kind of signs and symptoms you think about with a stroke, well, let's talk about the symptoms. So for one, they can be variable based on where in the brain the stroke is happening. So what part of the brain is being affected. The most classic example is a stroke that's happening on the left side of the brain is usually going to cause symptoms on the right side, and then vice versa. So it does depend the location in the brain where the stroke is happening. When a stroke is developing, when it's happening, it's sudden. It's always going to happen very, very suddenly, and it's usually going to manifest itself on one side. Some of the classic signs and symptoms you'll see are weakness of the face, the arms, the legs, specifically again on one side. Difficulty or slurring of the speech, facial drooping, some loss of vision, sudden severe headache. That's one of the telltale signs, just a really, really bad headache that just comes in out of nowhere. And then loss of balance, loss of coordination, dyspraxia, dyskinesia. So the pathophysiology for strokes is really pretty simple. There's just a lack of cerebral blood flow to tissue in the brain, and that leads to brain cell death. That's the pathophysiology. Now, it's very simple, but there are some key differences to discuss between the different types of strokes. We classify them into 3 main types. In truth, there's really only 2, but we do still kind of classify them as 3 separate types. So the vast majority of cases are what's known as ischemic strokes, which again is about 90%, and that's caused by a blockage via a thrombus or an embolism, a clot of some kind, or a hardening or stenosis of the artery. There's also what's called a transient ischemic attack, which is basically an ischemic stroke that doesn't develop into what we would call a full stroke. So you can almost think of it like a mini stroke. It means that blood flow is diminished to an area of the brain, but it's not completely occluded. And so we don't classify it exactly as a stroke. We call it a transient ischemic attack or a TIA. But it is still significant, it is still serious, and it can indicate that someone could develop a stroke either immediately or further down the line. And so then the last kind of stroke, which is a small minority of strokes, but it's still significant, and the way we treat it is very different. So it's important to distinguish between the ischemic strokes and this last type is what's called a hemorrhagic, which is when a blood vessel in the brain ruptures. And this can happen in different places. It can happen in the intracerebral space, so that means that the bleeding is actually happening inside of the brain, or the subarachnoid space, which is in the space around the brain. So bleeding in either of those places would be a hemorrhagic stroke. And the symptoms and signs are fairly similar, but again, the treatment and kind of what it means is going to be a little different. So as I mentioned before, the ischemic strokes account for 90% of all strokes. They are typically caused by an embolism or a thrombus in combination with atherosclerosis or arteriosclerosis. They typically occur very rapidly, but they can progress slowly. So they all of a sudden symptoms might come on, but the symptoms might not be very pronounced. So they could start out as a transient ischemic attack and then worsen over a few hours, maybe even over a day or two, into a full stroke. As that happens, if that happens, we call that a stroke in evolution. And again, the symptoms become gradually worse and worse until we see brain death or brain cell death. And then at that point, we call it a full stroke. So again, it's a blockage of some kind or a stopping of blood flow to a part of the brain. So a TIA or a transient ischemic attack, again, you can think of it like a mini stroke. It's typically, they last for a brief period of time and they typically resolve themselves. So that means they generally get better. Either the clot kind of moves on to a larger section of the artery, and so it's not causing as much of an occlusion anymore, or the arteriosclerosis or the hardening of the artery, it relaxes or something happens and it resolves itself. But they can develop into strokes. In addition, they can happen as almost like a warning sign to a stroke. Like you might see someone having TIAs and then a little bit later they develop a stroke. Because again, if there's a clot, for example, that's kind of floating around inside their arteries, it could maybe get in one place that causes a TIA and then it gets passed along, and then maybe a little while later it finds its way into another artery where it actually gets lodged, and then it can't be dislodged, and then there's no blood flow. So the symptoms are generally the same as what you'd see in a full stroke, cerebrovascular attack or cerebrovascular accident, but they tend to be a little bit less. But generally, they're very similar to a stroke. They just haven't resulted in brain cell death yet. But again, TIAs can develop into strokes. If someone has a TIA, they're at really high risk for developing a stroke later on. So again, you could think of them almost like mini strokes. But it's in the name, transient ischemic attack. It means that it's a transient, a short-lived ischemic attack. So the other type of stroke that's non-ischemic would be a hemorrhagic stroke. And so this is caused by bleeding in the cerebral artery. So again, the pathophysiology is just that blood can't get to the part of the brain because the blood's leaking out of the aneurysm or the place that is developed where the hemorrhage is occurring. But it also means that as blood pools inside or around the brain, it puts pressure on the brain, and it leads to increased intracranial pressure. And so that also leads to a decrease in blood flow. These happen very suddenly. So just you almost snap your fingers and then you start to see these symptoms. They oftentimes are associated with activity. So it's common, after a head injury, like a traumatic brain injury or something like that, they can develop into a hemorrhagic stroke. So somebody gets into a car accident, or maybe they're playing a contact sport, like football or boxing or something, and they take a blow to the head, and it can cause a hemorrhagic stroke. But sometimes that doesn't even require that. The signs, again, can be the same or similar to an ischemic stroke, but they tend to be very sudden, and they also tend to be a little bit more associated with changes that result or symptoms that result from an increased in intracranial pressure, right? So vomiting, sudden severe vomiting that doesn't have associated nausea, really bad headache, sudden seizures, changes to one side of the body where they have really severe weakness or drooping, very quick decreased level of consciousness. And again, if you were to have them set up to like an intracranial pressure monitoring device, it would show a sudden increase in intracranial pressure, but usually they're probably not going to be on one of those. They're just going to be having that, and you'll see the symptoms. The big difference, and the big reason why it's important to distinguish between hemorrhagic and ischemic strokes, is that we do not, under any circumstance, use anticoagulants to treat a hemorrhagic stroke. I would think that would be pretty obvious to all of you. You're all in Surg 2 now, and it should be pretty pretty easy to figure that out. But with ischemic strokes, there's almost always a clot or some kind of thrombus formation, and so anticoagulants are a go-to therapy to either resolve the stroke or to help prevent another one from occurring. In hemorrhagic strokes, we do not, under any circumstance, want to give them anticoagulants, because again, it's only going to prolong the bleed and it's only going to make it worse. So one of the first things that we do when we have someone that comes in with signs of a stroke is we need to differentiate between whether it's an ischemic or a hemorrhagic stroke, so that we can then begin to treat it. The only other thing is that within a hemorrhagic stroke, it's also typically the case where their blood pressure is very high. And so we want to keep their blood pressure under control, because the higher the blood pressure, again, the worse the bleeding can be, and it can make the hemorrhage a lot worse. So the way we diagnose a stroke is through imaging. That's pretty much the way that we diagnose a stroke. And the go-to is the CT scan. So you can also use MRIs and X-rays, but the CT scan is best because it gives us the most information in the quickest amount of time. And so most facilities have what they call a door to CT time, and it's basically they're measuring, as part of their quality improvement measures, things that they track in the hospital, especially in the emergency room. And basically what they're looking to do is get the time it takes for someone who is admitted with stroke or stroke-like symptoms to get a CT scan. They want that time to be as low as possible. So ideally, we want a CT scan done and then interpreted within 45 minutes of admission. That is like the gold standard. But facilities are always trying to get that door to CT time down. And that is a big deal because, again, the sooner we get the CT scan and the sooner we can, one, identify that it is a stroke, and then two, which kind of stroke it is, the sooner we can begin treating them. And the sooner we begin treatment, the better the prognosis is generally for the patient. Some other ways that we can use to, usually not done so much to diagnose for a stroke that's happening, but to help give us a prognosis for recovery after a stroke or potentially evaluate for risk of stroke. One is the plaque test, which is just a screening tool that measures for enzymes that are present within the serum that predispose an individual to a stroke. The other is the National Institute of Health Stroke Scale, which basically helps assess the neurological status of a patient. And so this isn't, again, used so much to diagnose a stroke. It's more to give a prognosis or to kind of measure somebody's ability to recover or how they're recovering from a stroke. A lot of times, a much quicker way of evaluating this, though it doesn't give as much information, is what we call the Glasgow Coma Scale, which I don't believe you'll have learned about yet. You'll learn about when you discuss traumatic brain injury. But the Glasgow Coma Scale is basically a measure of how comatose or how responsive someone is. So the higher the number, the better. The lower the number, the worse. So the highest number is a 15, and a 15 basically means that you're alert, you're oriented, you're talking, there's really no deficits. And then all the way down to, a 0, which would be basically that you're dead, or a 1, which would be that you're comatose and you have, no response whatsoever, no brain functioning whatsoever. So the Glasgow Coma Scale or stroke scales can be used to help figure out the prognosis for individuals if they're having a stroke or if they're recovering from a stroke. So this is just a visual of the NIH stroke scale. You can see that it basically is having you tally up, a lot of different factors such as the level of consciousness, the strength and the coordination of the different arms and legs, the ability to communicate, to use language, the ability to sense pain and other things. So again, the score might change over the course of days or even weeks. And just generally, the better a score is, the better somebody's prognosis is. It's, again, not really meant to diagnose a stroke. It's more just, another means that we can use to kind of test and monitor someone's progress or monitor their prognosis. So when we talk about the complications of a stroke, again, there's a lot that are short-term, and then there's a lot that are long-term. So some of those short-term effects are going to be, like sudden seizure, sudden headaches, loss of feeling or coordination in one side of the body. But some of those things can also persist past the point of recovery. So most of what we're going to talk about now are kind of managing some of those things that can stay with somebody after a stroke. But again, a lot of these things can also be present when someone has a stroke as well. So a big complication is changes to individual like sensory and perception. It can mean changes to how someone sees, their ability to taste, sensitivity to pain or temperature. So a few common problems that people have is changes to their proprioception, which is basically their ability to sense where they are, for their body to basically recognize where it is. So it's very hard to describe because it's something we all take for granted, but basically it's like that knowledge of, you understand without even thinking about it where your arms are in relation to the rest of your body. But changes in your proprioception can mean that, you feel like your arms aren't where they're supposed to be. Hemianopia, which is a change where one half of the visual field in one or both eyes is lost. And so this should be clarified. This doesn't mean that you lose sight in like the right eye. What this means is that the right side of your visual field in one or both eyes would be taken away. And so that would mean that basically you could have a loss of the right side of your vision in your right and left eye. And so it's almost like for each eye, if you were to cut their visual field in half, so you'd still have sight in both eyes, but only half of their visual field. So you'd have a blind spot, if it was on your right side, you'd have a blind spot to your right, but you'd also have a bit of a blind spot right in front of you where your left eye sees, like the right aspect of your left eye's visual field, if that makes sense. Another common problem is agnosia, which is when you can't recognize objects or subjects. You see them, but you're not able to identify what they mean or what they are, or what they're used for, even though they're very common. And then apraxia, which is when you can't carry out motor function, even when the strength and the coordination are present, you're just not able to coordinate the gross or the fine motor movement to actually make it happen. So I want you to look at this picture for a few moments. Just take a look at it over, try to identify some of the objects in the picture, and then you can pause the recording if you want, and then start it up, and I'm going to talk a little bit more about it. So what's in this picture, what you're looking at is basically a approximation of what it's like to have agnosia. It's meant to mimic what somebody who's had a stroke or suffered from a stroke actually experiences when they're unable to identify something or unable to recall what some really common object like a toothbrush is. And so if you look at this picture, a lot of the things in it, it's like they're almost identifiable. Like you can almost tell what they are. They all look familiar. The picture itself looks somewhat familiar, and it looks like it could almost make sense, but it doesn't quite. So hopefully you didn't get a headache or got too much anxiety from looking at it. Hopefully it didn't cause a stroke in yourself as you looked at it. But again, the point is to hopefully give you an idea of just what somebody's going through and help kind of experience what that's like for someone who's suffering from agnosia. So as a result of a lot of these changes, one of the things that can happen to individuals who've suffered strokes is something called neglect syndrome, which is basically a situation where, because of the fact that most strokes affect one side of the body, or that they can affect just one side of the body more than the other, where basically the patient ignores that side of their body. They have, what they consider to be a good side and a bad side. And so they start kind of doing everything with their good side, their unaffected side, and they kind of leave their affected side alone. They don't really engage it at all. And so this is bad because it can actually mean that the individual loses even more use of that side, and it can make their overall quality of life a lot worse. Um, so one of the things that we want to do is we want to try to engage that affected side as much as possible. We want to try to get them to focus on using it and try to focus on kind of trying to compensate for it and help use it as much as possible, because it'll help prevent this neglect syndrome. So I want you to take a moment, especially thinking about that last slide, and neglect syndrome specifically. And what kind of nursing problems do you think that neglect syndrome could cause for a patient? And more generally, other changes to their sensation and perception. And then think about what would we as nurses do to manage it. So you can pause this and restart it, and then I'll talk a little bit about some of the things. You might think of some of them. You might think of even some that I don't mention. Okay, so some of the problems this could cause. Well, one, changes to temperature regulation and pain perception mean that it's very easy for individuals to injure themselves, or for others to injure them inadvertently, right? So like a really good example that's somewhat easily avoided, but it's still present, is drawing a bath or a shower that's too hot. And so that's why we make a big deal about always testing the water before you start giving somebody a bath or a shower. Because you can cause serious harm to someone if they have that loss of temperature perception. Another issue, thinking again about that last slide, specifically neglect syndrome, is that it makes it a lot easier for individuals to fall, especially if they're not doing things like scanning. So what I mean by scanning is specifically with somebody who has hemenopsia or any other kind of change to their visual field. We actually want to encourage them to look around and to actually turn their head, almost like they're crossing the street, to constantly be doing that, because it makes up for the loss of their visual field. And so one of the things that we want to do to help promote, or not promote, but help disincentivize this neglect syndrome from happening and help promote them using their affected side, is we actually want to place commonly used objects on their affected side. So if they have like visual problems that cause them to lose the right side of their visual field, we actually want to put things like the call light and their controller, or maybe their cup and things like that, on the right side, where they aren't able to see it when they're just looking straight ahead. And the reason, it almost sounds like it's cruel, but it's not. What it is it's helping to train the person to scan, that they have to look. And so that way they're constantly getting used to scanning, and they're constantly used to accommodating and for that change to their visual field. And so that way when they're out walking around or they're out doing other things, they're scanning, and they're not going to be taken unawares by somebody who's in a blind spot. They're constantly kind of inadvertently training themselves to make up for that blind spot. It also means that they're forced to use that affected side, and so they're forced to use their weaker or affected arm, and so it is able to maintain some of its functionality. Obviously, in cases where they have complete paralysis, it'd be cruel to put like a call light in that affected arm when they can't use it at all. But generally, if you can, you want to try to do this if it's reasonable, and especially with changes to the visual field, because it means it's going to help prevent potential injury to the individual in the long term. So there are also cognitive and behavioral changes that are fairly common after a stroke. These can range from just short-term confusion in the immediate period of a stroke, where the individual just maybe loses some of their orientation, all the way to being in a coma. And it could be a coma they never recover from. It depends. Or they could have a stroke that puts them into a coma, and then they come out and they have no real deficits. That's fairly rare, but it can happen. So again, there's a wide range of cognitive and behavioral changes that this can cause, but generally it is common or it's possible anyway, for symptoms like emotional lability to occur. Basically, they're a lot more prone to extreme emotions, either anger or laughter, happiness or sadness. They tend to be a lot more impulsive and have a lack of self-control. Again, this isn't true for everyone, but it's something that has been observed. And then also memory loss is very common. So this typically is shorter term memory loss. It means that sometimes individuals have trouble remembering things, they have poor judgment, and they're less able to recall recent information. But again, the level of confusion or level of memory loss can vary very widely. So it really just does depend on the individual. Another big problem is problems of communication, specifically aphasia. And I believe this is something y'all have already learned about, specifically in older adult. But aphasia generally is an inability to use or understand language. So there's three types of aphasia that we describe, and that's expressive aphasia, which is when you can understand when you're spoken to, but you cannot speak back. There's receptive aphasia, which is when you're able to speak fine, but you're not able to understand when others speak or communicate with you. And then there's global aphasia, which is basically just both. You can't understand others and you can't speak for yourself. There's another, it's almost like aphasia, but it's not quite. But there's another impediment to effective communication after a stroke that can occur, which is dysarthria. And dysarthria is different from aphasia in that it's not a cognitive problem. It's not a lack of cognitive ability to process what's being said or what you're trying to say. It's a physical motor problem. So it's difficulty using the muscles and the parts of your body required for speech to actually sync those up and use them effectively. So it's more of a motor skills problem, and it's something that speech therapists work with patients a lot to help improve. So I want you to think about some of the implications it has for us as nurses caring for a patient with aphasia, and then think about what kind of nursing interventions we can help to manage some of those implications and complications. So take a moment to think about that. Again, you can pause this if you want, and then I'll kind of talk about it a little bit. So obviously, most of those implications are going to mean difficulties communicating. So a lot of it's going to be how do we deal with the lack of a patient's ability to communicate with us, or for us to get our communication across to them. One of the things that we can do is we can use things like image boards. That's very common, especially with patients who speak other languages or young children. We're even just using a pain scale that has frowny faces and smiley faces on it that kind of indicate how bad someone's pain is. But using it for other things, for common things can be very useful. Again, depending on the type of aphasia the person has, they might also not be able to interpret pictures or even written words. So some of this is variable depending on the individual. Additionally, using things like just writing paper, if the person's able to write or you're able to write to communicate with them, can make it easier. A big thing that is true for most folks with aphasia is it's important to have a lot of patience, because one of the major problems that happens as a result of being aphasic is that individuals tend to be kind of short-tempered. It's very easy to get frustrated. And I mean, that seems kind of natural. Think about it if you're trying to communicate with somebody, but you can't understand them or you're not able to get the words out that you want to. It can be very frustrating. So we want to make sure that we give these individuals plenty of time. We don't want to hurry them. We don't want to do the thing that you've probably seen nurses or maybe even family members do, where you almost like play a charades game with them where you're trying to guess what they're trying to say. You want to try to avoid that, because again, that can add to the frustration as you're trying. It comes across as you're trying to rush them, and then also it's going to frustrate them more if you don't get what they're trying to say. It also makes them feel like they're being cut off. You don't like it when you're interrupted. And so it's the same here, where the individual doesn't want to be interrupted. It's just harder for them to get out what they're trying to say. So motor dysfunctions are also pretty common. Most people associate strokes with weakness, paralysis, or just generalized motor dysfunction on usually one half of the body. It can happen to both sides, but that's one of the things most commonly associated with strokes, even by a lot of lay people. So again, it's usually one side, but it can affect both. Another serious problem that can happen is spasticity of the muscles, which can lead to contractions, especially in the hands, the arms. You can also have foot drop. All these contractions and problems end up meaning that the individual has a lot less ability to perform ADLs, and in some cases might even keep them bedbound. So it's really important that the nursing care we provide focuses on ensuring that we're doing range of motion, that we're preventing contractures, and we're preventing all those problems related to, potentially immobility, but also just lack of use of whatever extremities are affected. So in terms of the general prognosis that somebody has after a stroke and their mobility, it really depends on the individual case. Some people might have a really good prognosis. Some people can have a stroke and then, within a few weeks they're up walking around again. There are people who have strokes and they run marathons, but it, isn't always like that. And obviously, comorbidities, especially like the older you are, the worse the stroke is, any other like medical problems you have, those can all play a role. So the long-term prognosis is really variable. Some of the collaborative healthcare providers that you might work with, physical therapy tends to work with more gross motor movements, so walking, sitting, standing, getting around, that's usually physical therapy. Occupational therapy deals with more fine motor skills, so activities of daily living, and just fine motor movements. And then speech therapy usually is who works with patients for obviously their speech and their communication, but they also help with swallowing, as sometimes patients have difficulty swallowing, and so that also falls under the purview of speech therapists. So see if you can think about some patient problems or nursing diagnoses that would fit with a patient that has altered mobility related to a stroke. So what kind of nursing diagnoses would be appropriate to address some of those issues? What would be some of the goals that you might have in mind? And then what would be the interventions that would help you address those complications? Elimination issues are also somewhat common after a stroke. Some of these have to do with some of the other complications of stroke, so sensory perception issues or motor deficits. So problems with elimination can just be, frequency, urgency, they can be incontinence, and they really, just how we address them really depends on what the cause is. It could be that the patient has a weaker bladder sphincter, and so they're not able to retain as much in their bladder before they feel that urgency. It could be that they have impaired mobility, and so they're functionally incontinent, where they, it's just an issue of they can't get up in time to go. So really how we address it depends a lot on what it is that's causing the issue. So again, same as the previous slide, take a few moments and see if you can think of some nursing diagnoses that could be appropriate, and then how we would address those problems related to elimination in a patient with stroke. Another common problem that affects about half of all stroke patients is what's called post-stroke fatigue. And it really is just exhaustion, just fatigue that happens after a stroke. What's unique about this fatigue is that it's usually not relieved by rest or sleep. There's really not a complete understanding of why it happens. A lot of the thought is that it's at least somewhat tied in with anxiety and depression following a stroke. This can be significant because, obviously when you're feeling tired all the time, it's not like a good feeling, but it can impact and affect how the patient's recovery goes with some of the other deficits or problems they have. So, it makes it a lot harder to actually engage in physical therapy if you're too exhausted to get up and move. And so it can actually make recovering from the stroke a lot more difficult. So again, there's not a lot that we can do. We just, a big part is being patient with our patients, allow them time to rest, even though a lot of times rest isn't as effective, it's still good. Because it ties in a lot with feelings of anxiety and depression, trying to be positive and focus on the positives of the rehab is really important. A lot of times patients will be very down on themselves and down on their progress. It's a kind of difficult to go from potentially being, 100% active, and fully capable of taking care of yourself, adult, and then in the span of a couple weeks, you're dependent on other people for your help, or you're not able to walk even, 20 feet to the bathroom. So one of the things we need to do is try to be encouraging. The other thing that can sometimes be difficult for patients to deal with is the fact that recovery isn't a straight line. There might be days where you do really good, and then other days where it's not so good. And so kind of focusing on that and highlighting the overall trend. Sometimes it's a case where the patient will look and they'll be like, oh my gosh, yesterday, I was able to walk this far, and today I can't even get that far. And you can kind of phrase it as like, well, look, yeah, you're right, it's not a great day, but think about where you were a month ago, or something like that. Sometimes, again, focusing on those positives can be really good. And then, again, not having a rushed approach, allowing the patient time to do skills and not trying to make them feel rushed or make them feel like they're not doing it quickly enough or to your satisfaction. A lot of forms of pain are also common after a stroke. These can range in terms of the intensity, the duration, the cause. Some of it can be a result of other complications related to the stroke. So, again, some of those hazards of immobility or things. But again, regardless of the case and the underlying cause, the pain can get in the way of rehabilitation because obviously, patients aren't able to get up and do as much when they're under a lot of pain. One really common problem after a stroke are headaches. They're very common. And these sometimes will improve after the stroke. So, they're really bad, and then over the span of a few months, they kind of lessen or go away. But some people report having headaches the rest of their life. And this is even in individuals who haven't really had a history of like chronic headaches previously. So dealing with long-term chronic headaches is sometimes, a symptom or a side effect of having a stroke. Another thing that can cause some of these headaches is in the case of hemorrhagic strokes specifically. There is a time period following the stroke where the blood that has leaked into the brain and the central nervous system, it's being reabsorbed. But as it's being reabsorbed, it leaves behind some trace iron, and that iron is really irritating to the brain and the spinal column. And so for about a month following a hemorrhagic stroke, really acute, really intense pain that almost kind of migrates down the spine can be common. And unfortunately, there's not a lot that can be done about this other than just giving, pain medicine. It's not permanent. It can sometimes feel like, the patient's like going to be in pain forever. They're like losing control of their body or something. But it's a temporary thing. Again, it can get in the way of rehabilitation, but it is temporary. And so it's just something that has to be dealt with. So getting into medications we use for strokes. Again, a lot of our goal in terms of stroke therapy is to not ever have to provide any stroke therapy and to actually prevent a stroke from ever occurring in somebody. So one of the major contributing factors to strokes is hypertension. And so giving antihypertensive medications is oftentimes a good preventative step, for strokes. In addition, we oftentimes will give anticoagulants to prevent strokes. And so one of the more common ones is what's called clopidogrel, or probably a lot of y'all know it as Plavix. And this is a drug that makes it so that the platelets are less likely to stick together. They're not able to coagulate as well. And then another drug that's very common is aspirin, which aspirin, has another purpose, which is used to treat pain. But aspirin can also be used to help prevent stroke by acting as an antiplatelet, and it also helps prevent coagulation. The one thing to remember about aspirin is the dose that we give in stroke prevention or stroke treatment is different than the dose we give for pain control. Generally speaking, when we talk about giving an aspirin for stroke prevention or stroke management, we talk about giving a quote unquote baby aspirin, which is a dose of 81 milligrams. So when you see a dose of aspirin that's 81 milligrams, that, in every instance I've ever seen, and probably every instance you'll ever see, means that it's there for anticoagulation purposes. So, when you're with your instructor, passing meds in clinical, and, you see your aspirin on your MAR, and they ask you what it's there for, don't say pain, don't say pain control if it's an 81 milligram dose, because that's not what it's for. Aspirin can also be given a lot of times immediately following a TIA or a stroke, and this is to help prevent a recurrence or help prevent the problem from reoccurring. So it's usually used preventatively, but it's also prescribed after in a lot of cases of stroke. So all that's prevention. What if we're not able to prevent one, or what if one happens? So in that case, the go-to are anticoagulants. We want to use anticoagulants to help control the clot that's formed. Again, this is only in ischemic strokes. In hemorrhagic strokes, we do not want to give any of these medications because they can exacerbate the problem. So the most common anticoagulants you'll see used are heparin, Coumadin, and enoxaparin. Those are the drugs that you'll typically see. Heparin, warfarin, and enoxaparin, Coumadin being the trade name. Another one that y'all may or may not have learned about yet is what's known as tissue plasminogen activator, or you'll hear it referred to by most nurses as TPA. And this is an antifibrinolytic. And what it does is it helps to basically dissolve clots and break up clots that are already present. So if someone has a stroke and it's confirmed to be an ischemic stroke, this is oftentimes given on entry to the emergency room. It's really important though afterwards to monitor for signs of bleeding, because with TPA, one of the major side effects is bleeding. And so even though we're treating an ischemic stroke and we're trying to dissolve clots and we're trying to keep them anticoagulated, because it breaks down clots that have formed, there is a high risk for bleeding, so we want to monitor for that. The only other instance where you might see TPA given, and I'm only mentioning this because you'll sometimes hear nurses ask for it or use it on the floor in cases where there aren't strokes, but in very, very low dosages and concentrations. It's also sometimes used to break up clots that may have formed in intravenous lines, so central lines. Not always, but in some hospitals they will use very small, very low dosages and concentrations. So don't confuse the two, obviously. But yeah, that's the only other instance that you might see TPA used. So warfarin is probably the most common anticoagulant that we prescribe post-stroke outside of just a baby aspirin. So you'll also hear warfarin called Coumadin, which is the trade name. It's an anticoagulant. So all of the standard precautions that we would apply to someone who is on anticoagulant therapy apply. They need to be on bleeding precautions. For warfarin, we want to monitor the prothrombin time, which is the PT level. The PT is oftentimes expressed as what's called INR, which just stands for International Normalized Ratio. And INR, again, is just another way of expressing the PT value. So usually INR is what you'll see listed, but you can use either. They're really giving you the same value. Because INR, again, it stands for International Normalized Ratio, it's a ratio. So if someone isn't on warfarin, what we would want to see their INR level at would be a 1, because it's 1 to 1 is the ratio, right? That's the quote-unquote normal. So if you're not on like warfarin at all, that would be what you'd want to be on. If though you are on warfarin, we don't want you to be normal, because we actually want your INR, your prothrombin time, to be elevated. And so in that case, we want the INR to be between about 2 and 3. That's the therapeutic range for an INR. Anything above 3, and that starts to get a little too high, and then there might be an overdose, there might be a situation where the dosing needs to be adjusted. Anything under 2, that also, potentially the dose needs to be adjusted, and they're not getting enough of the anticoagulant. So again, it's sometimes possible to see it expressed as PT as well, but INR tends to be the most common measurement that we use to monitor how effective it's being. And of course, the antidote to warfarin is vitamin K. So if somebody's on warfarin and they are overdosing or they have too much, giving them vitamin K will reverse the effects. Immediately following an ischemic stroke, it's also very common for a patient to be prescribed heparin. However, most of the way that y'all are familiar with giving heparin is subcutaneously and using it to prevent DVTs prophylactically following surgery or on admission to the hospital, something like that. The way that heparin is given following a stroke is it's almost always given IV. And so the heparin is delivered IV via a continuous heparin drip. And the way that we deliver this is, again, it's just like any other IV drip, and that it's hung in a bag, it's run through an IV pump, an Alaris pump, but there's a little bit extra that we as the nurse have to do. So the way this works is that the physician will order a baseline or a starting rate for the heparin drip, whatever that is, whatever amount they want to give. And it depends on the patient's weight, their age, a lot of other factors. Once they've made this order, we're going to draw partial thromboplastin time, or PTT, which is how we usually measure the effectiveness of heparin therapy. And then that first PTT is going to most likely look to be in normal range. And we don't really pay attention to that, but it's just to get a baseline. And then what we're going to do is we're going to, every 6 hours following that initial PTT and the initiation of the IV therapy, we're going to draw a new PTT. And we want to keep that PTT between 1.5 to 2.5 times the normal level. Again, how much exactly depends on what the physician orders. Then what we're going to do every time we draw that new PTT level, so every 6 hours, as the nurse, we will need to evaluate whether the rate needs to be changed or not. And if it does need to be changed, we are the ones who will change the rate. So we're constantly monitoring and constantly adjusting the rate. So the physician will order a rate to begin with this heparin therapy. However, once it has been initiated, it's on us as the nurses to adjust it based on the sliding scale that the physician is going to give. So similar to like an insulin sliding scale where, you're not told how many units to give every single time you draw a glucose check, you're given a scale that lays it out ahead of time. So it's very similar to that. So this slide is an example of what you might see for a heparin drips heparin scale, or the PTT scale. And so again, you would have a heparin drip that's running at a specific rate already. So when you look at this, you already have your heparin running through the IV. And then you would have drawn a PTT, and if you look on the far left column, you'll see what the PTT value ranges are. So if you had a PTT value that was 37, if we look on the second row, that first column, a PTT of 35 to 45, right? And we said 37. What we have to do is we have to give 40 units per kilogram as a bolus. So we draw up that many units and we deliver that as a bolus. So, if our patient was 10 kilograms and, it says 40 units per kilogram, that would mean that we would deliver a 400 unit of heparin bolus. And then if we look to the right, it says increase the infusion rate by 2 units per kilogram per hour. So again, if our patient is 10 kilograms, that means that we are going to take our infusion rate and we're going to increase the rate by 20 units per hour, right? So we're going to increase it by 2 units per kilogram per hour. I'm just using 10 kilograms because it makes the math easier, right? If the PTT had been 50, let's say, that would mean that we don't give a bolus, but we still increase the infusion rate. If the PTT was between 60 and 80, according to this scale, that just means we leave it. That means we do not adjust the rate at all, right? And then as you can see, if the rate's too high, not the rate, but the APTT is too high, then we would decrease the rate or maybe even hold the infusion for a short period of time and also decrease the rate. And again, we're doing this every 6 hours. We're checking our PTT and then we're adjusting the rate that we give. Now, again, when you look at this, it's giving you an order to adjust the rate or give a bolus in units per hour. So that's what this says, units per kilogram per hour. However, we know that we don't program IV pumps to be in units. We have to program IV pumps to be in mils per hour. So one of the things that you may have to do is you may have to convert from your units to your milliliters per hour, right? And that will depend on the concentration of the medication that you have available and that you're delivering to the patient. So just keep that in mind. And there's a practice math problem on this next page that you can practice, and you'll have to use this scale on this slide to help you solve it. All right, so on this slide, I have a math question for you to practice, and I'll give the answer at the very end, but just to kind of help talk you through it, what we're trying to find is the new rate in milliliters per hour. So it reads, a patient has a bag of heparin at a concentration of 25,000 units in 500 milliliters of normal saline. Currently, that bag is running at a rate of 14 mils per hour. So again, we're coming in, this drip was started maybe a few days ago, and so they've been running with this heparin drip continuously, and every 6 hours we're checking their PTT, okay? And so right now, the rate is 14 milliliters per hour. The patient's weight is 70 kilograms per hour. Their most recent PTT was 50. So using the protocol on the previous slide, so that table that was on the previous slide, calculate what our new pump rate is going to be in milliliters per hour, okay? So take a moment to do that. Now that you've done that, again, once you've finished, the answer to the problem, again, don't listen to this until you've worked it through a couple times and tried to get it on your own. The answer to the problem is 16.8 milliliters per hour. We don't round it because we can initiate drips, IV drips, with tenths of a milliliter. So 16.8 mils per hour is going to be our answer. And if you have any questions about that, you can email me, and we'll talk about it some more in some scheduled time coming up if you have any questions. But again, the answer is going to be 16.8 milliliters per hour. This is a bit of a review, but I just wanted to pause for a moment and make sure that y'all remember what are some of the things that we need to ask our patients to do, or things that we as the nurse need to do for our patients while they're on warfarin, right? Because it's a very common drug. So what sort of problems are they at risk for? What sort of interventions do we need to provide? What sort of patient education do we need to give to the patients if they're on warfarin, especially if it's a new medication? So think about that. Try to remind yourself, if you don't know it, look it up. But just familiarize yourself with what are all of those things that we need to be aware of if our patient's on warfarin, and what do we need to teach our patient if they're on warfarin. So beyond medication, surgery is also a way to treat some strokes. And so there's a lot of different surgeries and procedures that are done. Again, it depends on what specifically is causing the stroke or what kind of stroke it is. So the first is an endarterectomy, which is when atherosclerotic plaque, so the plaque and the buildup on the interior of the artery, is surgically removed. There's also what's known as an arterial bypass, which is just when we take a vein or an artery from another part of the body and we use it to basically go around the area that is occluded or where there's diminished blood flow. So we're basically creating like a detour, right? So it doesn't have to, the blood doesn't have to go through that blocked artery anymore. There's also what's known as an angioplasty, which is typically it's done via balloon, so you'll hear balloon angioplasty, but it's not always done this way. But it's catheters inserted into the area, the artery that is occluded or that's closed off or that's stenosed. And again, typically a balloon is then inflated at the tip of the catheter that helps push the artery open and help open it up again, right? there may or may not be a stent that is then placed. Usually it's wrapped around the catheter or wrapped around the balloon. And so as it expands and pushes open the artery, it leaves the stent in place so that when the catheter is, or when the balloon is deflated and the catheter is removed, the stent actually stays in place and helps prop the artery open, right? So again, it's not always done with a stent, but typically it is done with a stent. And those have to be replaced every so many years depending on the make and everything. So these last two they're used for hemorrhagic strokes specifically. So clipping is when an aneurysm develops, and basically the point of the artery where the break is, basically it's clipped. It's just, there's a closing that's made so that where that aneurysm is, blood can't flow out of it anymore. Another common way to deal with an aneurysm that's resulted in a hemorrhagic stroke is what's known as a coiling, which is when the aneurysm, the part of the aneurysm that's protruding out from the vein or the artery is filled in with a metallic substance, usually platinum. And so it's basically a metal coil that's inserted into the aneurysm so that no more bleeding occurs. So clippings and coilings are done usually to control a hemorrhagic stroke that's developed. So most of those surgeries from the previous slide, they can be done via angiography. And so that means that usually there's a small incision made in the femoral artery typically, and then the catheter is inserted up into the offending artery in the brain. So typically they can be done via angiography. Some will require open head or brain surgery, what's called a craniotomy, where the skull is actually cut into and the surgery takes place there. So that's not the majority of cases, but that can be done. And obviously, if that's the case, there's a lot more post-op care that's required. Generally, in either case, all of that, the general post-operative care that you've learned about up to this point is still going to apply. If the patient has had a craniotomy, but sometimes also if they've had an angiography, but every single time more or less that they have a craniotomy, the patient's going to be placed on some form of intracranial pressure monitoring. And this is usually done via what's known as a ventriculostomy, which we're going to talk about on the next slide. But it's important to maintain and monitor the intracranial pressure of the patient, especially after they've had any kind of brain surgery. So getting into ventriculostomies, like I mentioned in the previous slide, these are one of the major functions is to monitor the intracranial pressure. And intracranial pressure is measured in millimeters of mercury, just like your blood pressure. The normal range for a person's intracranial pressure is usually less than 15 millimeters of mercury. So depending on the source you look at, you'll see less than 15. You'll also see 7 to 15 or 10 to 15 or somewhere in that. Generally, somebody's intracranial pressure is going to be between 7 and 15. Typically, most of the problems that we deal with where we're monitoring somebody's intracranial pressure, we're more worried about it being too high and not so much too low. It's not always the case, but generally it's the case. So usually we're more worried about it being too high. So less than 15 is what we really want to see their intracranial pressure at. So the way we monitor it, again, is through a ventriculostomy. And this is a drain that is placed inside the ventricular cavities of the brain. And there is a transducer that is at the tip of the ventriculostomy. So what's important to remember when you are using this system is that, again, this is a drain that's going directly into the brain. So it's very important to keep the entire system sterile because there's high risk for infection. And if the person gets an infection in the brain, that can be obviously very bad. It can lead to a lot of serious problems. The ventriculostomy also serves as, or it can serve as a drain. So in some cases, to help keep the intracranial pressure down, we want to actually drain the intracerebral space. And this can be maybe after surgery, there's still some bleeding that's occurring, or maybe it's just production of intracranial fluid. And so we want to, if it's being used to monitor drainage, we need to make sure that we're measuring and recording the amount of drainage, that we're also keeping the tubing free of any kinks or anything, and that we're keeping the site dry, intact. Another really important aspect in the care for ventriculostomy is that the drainage system itself has a transducer. And this has to be in line with where the tip of the ventriculostomy is in order for the pressure readings to be correct, but also to control the amount of drainage that's coming out, right? And so on the next slide, there's a picture showing what a ventriculostomy system will look like, and I'll talk a little bit more about that. So this is a picture of what a ventriculostomy setup might look like, right? And so the catheter is actually inside the person's brain, and you can see that coming away from it, it attaches to a drainage system, and then it's almost like it looks like a ruler almost that is attached to an IV pole, right? That ruler basically you adjust so that the transducer, which if you can see on the picture, it looks like a laser pointer, and it actually is a laser pointer. Some of the systems actually use a laser pointer to help you figure out the correct place to put them. Not all of them. Some of them just have like an arrow drawn on them. They're obviously the cheaper version, where they have some other marking to let you help line it up. But the purpose is we want to keep it in line with the ear of the patient. If we do that, that means that it's going to drain neutrally. That means that it's in line basically with the tip of the ventriculostomy. If we lower it, right, if we lower the drainage system, it's going to promote drainage because it works via gravity, right? So if for some reason we needed to try to increase the drainage, it might be ordered to be placed lower. If we were trying to stop the drainage, we would obviously raise it above. In either case, if you ever adjust that level to above or below the level of the ear, the intracranial pressure readings that you are getting from the ventriculostomy are going to be wrong. They're not going to be accurate, right? Because if you lower the transducer, that's going to make the intracranial pressure readings look a lot higher because the transducer is getting all that pressure, right? The drainage system's via gravity, again, it has more pressure coming from the brain. Similarly, if you raise the drainage system above the head, then the ventriculostomy is going to read that the intracranial pressure is dropping, right? So again, if you want to get an accurate measurement, you have to keep that drainage system in line with the ear. So it's really important whenever you adjust the patient's position in bed, the ventriculostomy has to be adjusted. Anytime the patient wants to get up or move, it has to be adjusted. And it's really important because, again, we're going to be monitoring their intracranial pressure pretty regularly. The other thing to keep in mind, though, is that, if the patient's moving around a little bit and their intracranial pressure is like jumping around, don't panic. Check and make sure that the ventriculostomy is in line with the ear, because if it's not, it'll give you some really crazy readings. So just remember that, and always check that if you see somebody's intracranial pressure is like changed a lot, or it's really high or really low. Check that first, because it can be really serious if it's too high, but a lot of times if it's jumping around a lot and it's been stable, it's because that system has been moved or adjusted in some way. So on this last slide, I gave you some nursing diagnoses. Try to develop these if you can. Think of what some appropriate goals might be, both short and long term, for a patient with these problems after a stroke. And then think about what kind of interventions would be appropriate to address those goals that you've thought of. And if you have any questions, please email me. We'll also have time to discuss this in a Zoom classroom during the time that was allotted for this class. So thanks.